Thank you for joining my presentation regarding angioembolization in pediatric blunt renal trauma patients. My name is Brittany Levy and I'm from the University of Kentucky. The algorithm for blunt renal trauma utilizes grade of injury and hemodynamic status to determine operative versus non-operative management. Recently, angioembolization has become a viable treatment modality for high-grade renal injury to achieve both hemodynamic stability and renal salvage. Direct comparison of renal salvage rates, in addition to secondary outcome measures, have not yet been studied in a large sample size. We first queried the National Trauma Data Bank for pediatric patients less than 20 years old who had ICD codes related to renal trauma. The NTDB provides an abbreviated injury score, which is easily converted into an AAST grade. We included grade 3 and higher. These patients were again segregated into those who underwent angioembolization and those that did not, and then it was determined if these patients underwent nephrectomy. Then secondary outcomes were analyzed. The demographics for our treatment and non-treatment group are comparable. Please note that there are 121 patients who are hemodynamically unstable at presentation, and a portion of these likely initially underwent nephrectomy. This is a limitation of our project. For our primary outcome in this patient sample, 92% of patients who underwent angioembolization did not require nephrectomy and had appropriate renal salvage. 55 children who did not undergo the procedure required nephrectomy. It is unclear if these were all part of the 121 children who arrived hemodynamically unstable, requiring immediate nephrectomy, or if these truly represent a failure of conservative management. Our secondary outcomes revealed that all statistically significant complications were present at a higher percentage in the angioembolization group. Further, these patients had an increased length of hospital stay. Although there is increased risk of adverse events associated with angioembolization patients, it is important to note that 92% of children did not require further nephrectomy. The question becomes, is long-term benefit of renal salvage worth the increased length of stay and higher adverse event profile? Unfortunately, that cannot be determined by our data set. Limitations to our study are related to the NTDB where we obtained our data, including being unable to delineate who was initially taken for nephrectomy versus those who failed conservative management. Further, we're limited by the years of data we had access to, given that this is a relatively new treatment modality in pediatric patients. We need to further examine which patients have a beneficial risk versus benefit ratio for renal angioembolization, given the known adverse event profile. The final goal should be implementation of a widely accepted algorithm for blunt renal trauma, which includes angioembolization as a treatment. Thank you for your time. I am now open to any questions.